Hello, and welcome to the Envision webinar on LF dossier development and the validation process, which will include an overview from the World Health Organization and practical experiences from both the national programs in Cambodia and Bangladesh. My name is Molly Brady. I'm an NTD Senior Manager for the Envision project at RTI International, and I'll be facilitating the webinar today. On behalf of Envision, thank you all for joining us. We hope you'll find the webinar useful in your work to eliminate. Muted. Let me introduce our speakers and the agenda for today. First, Dr. Jonathan King, LF focal point and scientist at WHO Geneva, will provide background on the LF dossier and the validation process. Then our panelists from Cambodia, Dr. Virak, manager of the National Helminth Control Program at the Ministry of Health, will share Cambodia's experience with achieving validation of elimination. He regretfully can't be with us in person today, but we have recorded his presentation earlier. Finally, Dr. Mohammad Karim, Program Manager of the Filariasis
Unmuted.
and STH Control Program at the Ministry of Health and Family Welfare in Bangladesh, will share his experience developing a pre-dossier. For those of you new to webinars, if you look in the top right of your screen, you should see the GoToWebinar toolbar, which provides guidance. You should be hearing the audio through your computer, and if that's not working well, you can call in through the phone by clicking on Phone Call in the audio section. At any time during the webinar, if you have questions for any of our presenters, please type them into the question box, and we'll do our best to address them in the Q&A time we've saved for the end of the webinar. There's also a copy of the WHO Validation Handbook available in the bar on the right side of your screen under Handouts. We'll be emailing everyone after this webinar with a copy of the Validation Handbook, this presentation, and a recording of the webinar. At the end, please take a couple of minutes to complete a short evaluation. Your feedback is very important to us so that we can make sure we're addressing the topics that are useful to you. And finally, if you find this webinar beneficial, you can find slides and recordings of our previous webinars on our website. Let me give a very brief overview of the Envision project. Envision is an 8-year global project funded by the U.S. Agency for International Development for the control and elimination of lymphatic filariasis, onchocerciasis, schistosomiasis, 3 soil-transmitted helminths, and trachoma. Envision currently works in partnership with national neglected tropical disease programs in 19 countries. For more information, please check out our website at www.ntdenvision.org or follow us on Twitter at RTI_FightsNTD. I also wanted to let everyone know about the NTD Toolbox for Preventive Chemotherapy Diseases, which includes the most used NTD guidance, tools and resources developed by WHO, Envision, and other organizations working in NTDs. You can find everything from job aids, WHO guidance, training materials, videos, and even the WHO Validation Handbook we'll be speaking about today. Access the toolbox on the Envision website, and you can search by disease or by NTD program phase for whatever you're looking for. I'll now pass the webinar over to Dr. Jonathan King from WHO Geneva, who will provide an overview of the LF dossier and the validation process.
Hi, everyone. I'd like to share some information about a new process we have at WHO called validation, and it's a way that WHO is able to acknowledge countries for their achievement of the World Health Assembly resolution target of elimination of lymphatic filariasis as a public health problem. And I'll talk first about the criteria of validation. As you know, in the global program, there are 2 aims: to stop the spread of infection through MDA and also to alleviate suffering. The criteria for stopping the spread of infection that we use for validation is that for 100% of the endemic area, so all endemic IUs would be able to pass a final task conducted no sooner than 4 years after the MDA has stopped. The target thresholds are listed here in the table and also listed in the monitoring and evaluation manual of the task. And these thresholds are measured during the task. But this is intended for programs that were endemic and followed the strategic framework. As you know, the strategic framework, we determine which areas are endemic through mapping in most cases. In an area that has greater than 1% MF or greater than 1% antigenemia, MDA is recommended for at least 5 years. And after 5 years of MDA with effective coverage meaning greater than 65% of the total population ingesting drugs each year, a follow-up survey is recommended. This follow-up survey in sentinel and spot check sites we've been recently referring to as the pre-TAS. And if an IU meets the criteria of less than 1% microfilariemia or less than 2% antigenemia in each one of those sentinel and spot check sites, then an area can proceed to the transmission assessment survey. And as you know, the transmission assessment survey tells us when an area has met those target thresholds, an MDA can cease. The TAS should be repeated twice, 2 to 3 years apart, so that that last TAS happens no sooner than 4 years after the MDA stops. At that point, when all areas pass TAS, then this criteria has been met. As I mentioned, the other aim is to alleviate suffering among those already infected with the disease. So these are patients with lymphedema and hydrocele. And the criteria for validation is that the recommended minimum package of care would be available to all areas of lymph patients. We refer to this as having achieved 100% geographical coverage. So what is that minimum package of care? We would define it as, and the goal is health facilities being able to provide that minimum package to every district with known patients, as mentioned. But what is that? That's the management or surgery for hydrocele, the management of lymphedema, and the treatment of acute attacks. There's also a strategic framework that can help guide programs of establishing the morbidity management and disability prevention. We would recommend first that a program undergo a situation analysis, identify the patients that are in the country and would require the basic package of care. In addition, the platforms that are already existing for which the minimum package of care can be integrated into the health system and sustained. Once the minimum package of care is being delivered, and prior to the dossier development and validation, we would prefer that there is some documentation of the quality and availability of the readiness of the health facility to provide the minimum package of care. And this is a facility, what is in this slide is a facility inspection, and that to give a program enough time to gather the information and document in the dossier should happen 2 years prior to the dossier development. Now, moving onward to the generic framework. So we say generic framework because this is a standardized process for all of the NTDs. And for those that are targeted for elimination as a public health problem, we use the term validation. And that involves the preparation of a dossier by the member state. The dossier documents all of the achievements in the country to support their claim that they have achieved elimination as a public health problem. The member state submits the dossier to WHO. WHO would identify a reviewing authority to review the information in the dossier and would decide to validate the claim or postpone until more evidence is provided. the way that the standardized process suggests that WHO will acknowledge the member state for their achievement is to receive an official letter from the WHO Director General stating that the program has been acknowledged for making this momentous achievement. And we also will update the status of the country in the Global Health Observatory, and we'll announce this in the weekly epidemiological record for the during the annual report of progress for the global program to eliminate lymphatic filariasis. Finally, in the process, the country must make a commitment to post-elimination surveillance. So whether we're talking about validation of elimination as a public health problem, elimination of transmission, verification, or eradication, the member state must commit to post-elimination surveillance. So the reviewing authority is established from the regional office of the WHO, and it's an ad hoc group, and their responsibility is to review the dossier. They include experts from LF Elimination that have not supported the development of the dossier and have no conflict of interest. They thoroughly examine the dossier individually, and they convene then to discuss the information provided in the dossier and then make a decision. They provide a summary report, and they recommend to WHO to validate the claim or postpone the decision. So this dossier is the key step, the first step, and the most important thing to develop to start the process of validation. What needs to be in that dossier? Well, the first thing is a clear description of how endemic and non-endemic areas were classified. It needs to document the interventions that were implemented to combat LF and the supporting data. You need to identify clearly the monitoring that was done and the data of those the monitoring. In addition, the transmission assessment survey results from all the endemic areas. A program also needs to report the number of patients with lymphedema, and in Wukuria-Bancrofty areas, the number of hydrocele patients throughout the country by the implementation unit. In addition, data indicating the availability and the provision of the basic package of care to manage patients already with the disease. So more specifically on the indicators required for morbidity management would include the disease burden, as I mentioned, estimates of the number of lymphedema and hydrocele patients per implementation unit, the availability of MMDP services, meaning the number of facilities providing the IUs with known patients, and the readiness and the quality of MMDP. So a preferred assessment of at least 10% of designated facilities, and this is the way to document the quality and the readiness. When should a country submit the dossier? So the dossier, we would recommend that it would be submitted only when every IU has passed task 3 during the post-MDA surveillance and the MMDP indicators are documented. And this is on a national level, not regional, state, or implementation unit, but on a national level. So when the entire country has achieved those criteria. Please do not wait until the very end to start the data collection. This needs to be occurring throughout the program. You should archive all the data from the inception of the program all the way through the end. This will make things very easy when coming to the time when the dossier should be submitted. So just to review the main actions of the validation process. The country program prepares the dossier. They submit the dossier from the Ministry of Health to WHO through the WHO representative. There is a deliberation of the dossier by the ad hoc reviewing authority that's convened by the WHO regional office. This reviewing authority then makes the recommendation to acknowledge the claim of elimination as a public health problem or postpone the decision. And then afterwards, there's implementation of post-validation activities, surveillance, and morbidity management to ensure that the achievements of the country are sustained. Thanks very much.
Thank you, Jonathan, for that useful overview. I'll now pass the webinar over to Dr. Virak from the Ministry of Health in Cambodia, who will discuss Cambodia's experience with dossier development and the validation process. Dr. Virak couldn't be with us today, but we have recorded his presentation earlier. If you have specific questions for him, please send them anyway, and if we can't answer them, we'll ask him to provide the answers and we'll post them on our website later.
First of all, I'm very sorry that I could not join you all in the live event due to my travel. However, I am very happy to share with you the experience of the development of lymphatic filariasis elimination dossiers in Cambodia. Let me start with some key information of lymphatic filariasis in Cambodia. Lymphatic filariasis was first reported in mosquitoes in the years 50 and 60. 40 years later, the lymphatic filariasis patient was with elephantiasis were found by the Médecins Sans Frontières team who actually work for malaria during that time. Since then, a national program to eliminate lymphatic filariasis was established, follow the global elimination guidelines. In 2004, Cambodian lymphatic filariasis program finished the mapping activities and came up with 6 IUs and 4 EUs, where about 500,000 people were at risk. The 5 rounds of MDA using DEC and albendazole were completed in 2009 with the coverage rate more than 70% at the first year, and the coverage rate of MDA was increased with time. There were several new infected cases were found in task 1, but they were below the critical cutoff number. And no new case was identified in task 2 and task 3. Therefore, our 3 tasks using ICT was passed. In late 2015, the Cambodian Ministry of Health submitted the elimination dossier to WHO for the validation. The success story of Cambodian lymphatic filariasis elimination will be soon found in the Journal of Infectious Diseases of Poverty. You see here some activities and timelines of the development, reviews, and submission of lymphatic filariasis elimination dossier in 2015. In total, it took about 6 months for compilation, development, reviews, and official submission. For instance, the consultant supported by FHI and RTI with NTD program manager took 4 weeks to compile and develop the dossier. The draft dossier was submitted to the RP-RG for the review. We then went back to the field to reconfirm the presence of Brucella malayi in 1 EU recommended by the RP-RG member. After reconfirm the absence of Brucella malayi in the EU, NTD program managers and consultants finalized the dossier, which took 1 week, and the final dossier was submitted to the Ministry of Health for the review and official submission to WHO. In September 2016, in its weekly epidemiological record, the WHO reported that Cambodia had eliminated lymphatic filariasis as a public health problem in 2016. 2 weeks later, a certificate of validation was officially handed over to the Cambodian Minister of Health by the WHO. Here are the lessons learned from the development of dossier until the official validation. From the beginning until the end of the elimination program, all relevant data and documents related to baseline, mapping, MDA, MMDP, tasks were well stored and ready to access. This helped us a lot to develop the dossier in very short period, 6 months. And last, the Ministry of Health took very quick action to review and submit the dossier to WHO. Two proposed activities to be considered after the validation. One is to disseminate this remarkable achievement by organizing the local and national stakeholder meeting. Second is to set up the post-validation surveillance integrated with the existing surveillance platform, for example, malaria, dengue, or other communicable diseases surveillance. Moreover, since we still do not have a post-validation surveillance guidelines from the global program, we propose to do an active surveillance in one EU in order to compare with passive surveillance. Finally, we would like to acknowledge all involved institutions at all levels for their contribution, and thank to the local and international development partners who had supported us. And we express our gratitude to Dr. Sinunut, our NTD hero, for her great work from the beginning until the eliminations of lymphatic filariasis in Cambodia. And thank you for your attention.
Thank you to Dr. Virak for describing the process in Cambodia. I'll now pass the webinar over to Dr. Karim from the Ministry of Health and Family Welfare in Bangladesh, who will discuss Bangladesh's experience with compilation of data for the dossier and writing up a pre-dossier draft.
Thank you. First pre-dossier document was prepared about 5 years before, and then it was updated every 2 years. This enabled us to identify the gaps in data and the work to be done. Dossier updating, collection and consolidation of data progressed simultaneously. The dossier has 6 sections in Word document and 1 Excel file with data. I will now present each of the 6 sections along with experience gained. This is under Communicable Disease Control Program under Director General of Health Service, Ministry of Health and Family Welfare. So we have background information. The demographic data was collected from the government publications like BBS, Bangladesh Bureau of Statistics, and other sources. Our population in 2015 estimated about 159.7 million in the total of 64 districts. Our health system has a strong network in the district, sub-district medical officers, and community health clinics. We have a community clinic that every 6 people in the village for 1 community clinic that was established and running smoothly for 6,000 people in the village level. LF program overview. We reviewed historical data and literature that has been done before in our country. And Culex Quinque fasciatus transmitted LF in Bangladesh, that is Ucheriya Bancropti. High prevalence was shown in northern 7 districts. LF elimination program launched in the year of 2000, and it is in 2nd operation plan of the country. A national task force headed by the highest person of the secretariat in the steering committee of this program. Section 2 is delineation of endemicity. We reviewed health records, survey data, and literature. From that, 19 endemic districts were there. And during preparation of pre-dossier document, prompted us to undertake additional surveys to determine endemicity in 15 uncertain districts. We had transmission assessment survey there in 15 uncertain districts that we thought that may be low endemic, and that all the 15 districts passed TAS 1 there. So no need of intervention like MDA there. Finally, very robust data are generated and to be presented in final dossier document that we'll be able to do. We have 13 non-endemic districts. In some of non-endemic district, we did TAS also. There we couldn't find anything. A lot of resource of additional work required to delineate endemicity and necessary for dossier document. Section 3. Interventions for interruption of transmission. Here, MDA was the core strategy as per WHO guideline. Initially, MDA data and processed were less organized. That means during the starting of MDA, field activities is not so easy. So we had challenges that time and initially, but after that, it was okay. And for pre-dossier document, data and processes were collected and consolidated. And you see, some districts we have 5 MDA, and some districts we need to do 12 MDA. And last district was Rangpur, that was done in 2016 July. And all the data are now well organized and available for final dossiers. Section 4. That is, it is epidemiological monitoring and evaluation of interventions. Actually, this preparation for pre-dossier document help us understand data requirement, and all the sentinel and spot check sites achieved less than 1% microfilaria rate. It took a lot of efforts and long time to collect and consolidate data. TAS 1, that is stop MDA deciding factor, completed in all 19 districts. About 47,000 children tested by ICT card. TAS 1 passed, and MDA stopped in district by 2016. As I told, the last district was Rangpur, and TAS 1 passed in last year in 2016. And this Rangpur required as many as 11 MDAs to pass in TAS 1. So most of the data required for final dossier are now organized and well managed. Section 5 is surveillance. So preparation and updating of pre-dossier document help us follow strict surveillance time schedule. That means TAS 2, TAS 3, that is the schedule is there. So we completed TAS 2 in 18 districts. About 43,000 children were tested and all passed. In view of dossier requirement, high quality of surveillance survey always maintained. So TAS 3 also completed in 6 districts, 15,000 children tested, maximum ICT card and some with FTS card. You know, FTS and ICT card we are getting through WHO channel. We cannot get another channel. Before we got the ICT, now we are getting FTS card. Ongoing surveillance plans are being developed and collaboration with partners. Section 6. Like morbidity management and disability prevention. That considerable number of surveys undertaken up to full dossier requirements. MMD, that is, we got patient searching. In frequent patient searching, so you can you can see the most of the cases are lymphedema. hydrocele in the male are there, and few others. So district-wise data is here, and you can see in the graph that in Rajshahi, Kustia, Chuadanga, highest from Pirozpur, that highest number of lymphadenema, and some hydrocele also. Others are few. MMDP care is available to the districts and sub-districts level hospital and at the community clinics in the village level. We directed to the community clinic that fix up a day like Tuesday for filaria lymphedema patient to how to care their health and how to prevent the acute infection. And we also supply some kit box like soap, antifungal ointment, like some sorts of those we can. So they are managing patient, and for challenge is there there is to bring the patient to the community clinic, because maximum lymphadenema patient, they are poor and female. So our partners are also working with the community people to bring them in the community clinic to manage the MMDP patient. So this about MMDP, but we need to strengthen more. Hydrocele surgeries are undertaken at all sub-district and district level health facilities. The program is going on for hydrocele surgery, and LSTM is helping us in this regard. So it's okay. More work in progress. Data are being collated and consolidated, and we are very confident to meeting the final dossier requirements in 2020. Benefits of pre-dossier. During the development of pre-dossier, we have this help the program, because this appreciate the data requirements, collect and organize data from different sources, verify, consolidate and prepare final data sets, strictly maintain timeline of various activities, particularly surveillance activities and MMDP, because these are the requirements. So our commitment is to elimination of lymphatic filariasis within 2020. So we have to follow the WHO guideline, and according to the guideline, pre-dossier is documented. So, and for that we have to be careful for all the activities. So it's helping the program in any other way. Technical support from RTI provided to be useful in preparation and updating the pre-dossier. This RTI technical support that is proved to be very useful to us, and this pre-dossier preparation prompted the following work to prepare final dossier. That is surveys in 15 uncertain districts that done already, surveys in 7 non-endemic districts closer to the endemic, bordering districts with the endemic, that we thought that is non-endemic. We did also survey in 7 non-endemic border districts with the endemic and pass the task. Updating of chronic disease burden and acute implementation of MMDP advantage. That means we are patient searching under the patient searching program. MMDP mapping is being done, so we can implement the MMDP activities there, and also development of ongoing surveillance activities. In meeting the final goal, this continuous learning and efforts enable to the Bangladesh LF Elimination Program to complete various program activities and prepare and submit the final lymphatic filariasis elimination dossier to WHO by the target year of 2020 that we are we are promising that we have to do this unless otherwise happen. Thank you, Dr. Kapa Ramaya, for helping us for pre-dossier documentation, and also RTI Innovation, WHO, and other partners. Thank you very much.
We'd like to thank the presenters for sharing their experiences. Let's take some questions for them. Please type in any questions you might have in the question box. And again, if you would like to download the validation handbook, please go to the GoToWebinar bar on the right side of your screen and look under handouts. We will also send the handbook to everyone that has registered. So we have our first question here. It's a process question, and this one is for Jonathan. What is the review process and how long does it take?
Thanks, Molly. The review process, as mentioned, starts with the dossier in the presentation, and it's reviewed by the regional authority, who then helps WHO make a decision on whether to validate the claim or to send it back. You will see in the validation manual that WHO has 1 year from the submission of the dossier and the request to be acknowledged from the country to make a decision and provide feedback to the country. However, it should take no more than 3 months from the time of the request.
Thanks, Jonathan. One other process question that came in is, does the dossier have to be developed by a consultant, or can national programs do it themselves? And if countries would like to have a consultant help them, does WHO have a list of suggested consultants?
So WHO is here to support a country that requests technical support to gather the data and put together the dossier. That's not required, but WHO will support countries that request this type of support. And when they do, we can make suggestions in consultation with the regional offices of an appropriate consultant that would be able to do so.
Thanks, Jonathan. The next question is a more technical question, and this is for Dr. Karim. Dr. Karim, when is a district considered uncertain for LF? How did you decide to do the extra surveys in those districts that were uncertain?
Thank you. Can you hear me?
Yes.
Okay. So, in the year of 2000, we did a baseline survey for MF endemicity. So, in that, the procedure was where there is more patient. So, we took the representative sample and did the survey. So from where we decided that 19 districts were highly endemic and 15 districts, maybe some, we found some cases, but microfilaria rate was not more enough that time in the survey. Anyway, so we started MDA in 19 districts. But later on, question arises in meetings, in RPRG, especially in 2013. How can you be sure in the mild endemic districts do not need MDA? So according to the recommendation of RPRG in 2013, we started task there in 15 districts, uncertain districts. So all the districts passed task 1, and also we did the bordering 7 districts of the non-endemic area related to endemic area. That also task 1 passed.
Thanks, Dr. Karim. Jonathan, do you want to add anything from the global perspective?
Sure. Thanks, Dr. Karim, and it's nice to hear your experience and how you were proactive in an area that you found MF cases, but it was less than 1%, which would indicate our threshold for triggering MDA.
Yes.
Then you used the transmission assessment survey as a tool for then determining endemicity, and that's acceptable. Yes. Countries can also use a survey. It's a probability sampling. I think it's being referred to as the mini-TAS, where 30 schools are visited and older age children are tested. This is also acceptable. And for any countries that are interested in this, they can contact me at King, K-I-N-G-J at who.int for a protocol, an example protocol.
Thanks, Jonathan. We have another technical question that has come in about the MMDP portion of the dossier, asking what methodologies do you use to establish the number of estimated patients for lymphedema and hydrocele? Dr. Karim, do you want to say a little bit more about Bangladesh's experience in estimating the number of patients?
Yes, sure. So first of all, we started our field workers in the early program activities, patient searching program. That means we had a workshop in the district level with the health worker, and we gave a form to all the health worker for searching patients in scheduled time, like 7 days, 10 days. Like this maximum we are giving 2 weeks. So within 2 weeks, they are searching patient door to door. That means they are these health field workers are from the village level, so they gave some remuneration for this, for everyday activity. So they are going house to search the patient. 1. Number 2, JICA did survey in 7 highly endemic districts, especially 5 districts. They worked there. They also searched patient. With that time in 2005, from 2005, JICA also worked in 5 highly endemic districts, and that we found in highly endemic districts by our health worker and JICA. Another thing we did in low endemic districts with the helping of local NGO funded by LSTM, and we followed a method by NGO, that is SMS tool method, that means mobile phone method, and we started that is with this NGO from 2014, and still is going on through SMS toolkit. That means the workers, that there is a team. So this team is also searching, and they are sending their information through a mobile phone SMS. This also we are collecting, but I cannot say still this 100% we could cover, but we are trying. You know, our population is more than that is about 34 million. Yes, in the 19 districts. But if we can tell in 34 districts, nearly 100 million. So big populations are there. We are working heart and soul, and maximum we could cover the patient searching and patient mapping. So this work is also going on. And for MMDP activities, that I can share my experience. So in the community clinic based MMDP center, we try to establish in the high endemic area and moderate also, and there we advise to fix up a date for MMDP patient. That patient will come to that clinic if they feel, so they will help how to wash, how to face acute attack, and health education to the patient. And in the sub-district level and district level also, we had training program with the health worker to manage the disabled patient. And hydrocele surgery campaign is ongoing with the fund of LSTM. We are also doing this. So LF program are now basically with transmission assessment survey, maximum task 2 completed, task 3 is ongoing. So in 2017 we could complete maximum task 3, and in 18 some of the districts task 3, and one district will be that in 2020. So now our main focus is now with the disabled patient, surgery for hydrocele and MMDP care. So program focus is mainly now is this, and task is a routine activities. So we are doing.
Thanks, Thanks, Dr. Karim. Yes, Bangladesh has done an awful lot to establish the burden of LF, of lymphedema and hydrocele, and to provide those services. Jonathan, do you want to talk about what some other countries have done as well?
Sure. I guess the first thing is that there's multiple options that are acceptable. And this could be anywhere from a health facility questionnaire that would report the patients seen through the health facilities, all the way up through the case search, as was discussed. But each option, you need to acknowledge that there's advantages and disadvantages to whatever method that you use. We have a situation analysis protocol that is available, and at the moment we haven't released that because we're considering including it as a web annex to a revision of the aid memoir that's currently underway. So this should be out soon. It is available. Again, you can email me if any program is interested to have a copy of the situation analysis.
Thanks, Jonathan. I think we'll move to another technical question that has come in. What happens if there is a new case after validation is completed?
All right, so this may occur during the post-validation surveillance activities, and by new case, we need to understand whether it's a lymphedema and hydrocele patient, and in this scenario, then for that patient, we need to ensure that the basic package of care is available to that patient. If there is someone identified as infected, either with MF or a positive FTS, or perhaps a Brugia rapid even would indicate perhaps an infection, then we anticipate this, that you will find some cases that those cases should be treated, and then the program should decide whether any further investigation is required. So is it just a single case, or have you found a cluster of cases which would perhaps trigger a different type of response? But this needs to be clearly planned out, I think, in post-validation surveillance activities and response.
Okay, I can say something. If during the post-validation survey, if a new case, the verbal autopsy should be done by the program. Likewise, is there any travel history and the infection type, and this any symptom of like lymphedema or hydrocele can occur 5 to 10 years after infection. So there is a range. If it is after 10 years, then this is within the period of the program. But even then, program can do some surveillance activity also there. Likewise, the house around 20 house or 30 house, like malaria is doing. So survey, night blood survey, or FTS, if there any infection, if there is no travel history from outside the country, then we can search for the local infection foci. So that can be, I think, recommended by WHO after this post-validation survey at that time. but program should look seriously for that new case, actually, I think.
Thanks, Dr. Karim. I know that is something that some countries are piloting in terms of what are the best ways to investigate those suspected areas afterwards. To follow up on that, we have another question about what should be done in terms of ongoing surveillance for new cases.
Thanks,
Jonathan.
Molly. Thanks, Molly. I think this is related to the previous question too. So, as mentioned in the validation process presentation and the standardized framework, the country must make a commitment to post-validation. And it's preferred that the program has already identified a platform and methods for post-validation surveillance. Now, this is a new area, and WHO is currently learning from the methods that are under operational research by the first validated countries. And this will help us develop more specific and perhaps standardized guidance on post-validation surveillance. But for now, it really is a setting specific based on the ongoing activities and available platforms.
So we have another question that just came in asking about whether any of these countries or others have used the WHO integrated NTD database in this process. I know that Cambodia did not because their data was collected before the WHO integrated database was available. Dr. Karim, do you want to say something about what kind of database you used for data collection? Dr. Karim? Are you there?
Can you hear me?
Yes.
So actually we are basically we are following out program data, historical data, and taking data, but we are trying now entity database inserting there, but we are facing problem with the software. So we contacted the person like Kalpana, and they are sorting what is the problem, because when we are trying to put in historical data, they are not taking. So entity integrated the data that we will make it, but it's taking time, and still we have individual program data, and maybe we'll get it this data if the software is okay working from here, then we'll put in this WHO entity database. Thank you.
Thanks, Dr. Karim. And just to say that the WHO integrated database is in the process of getting a standardized report that will be available that will be able to automatically generate the data needed for the Excel file for the dossier.
Yes.
We have time for a few more questions. One question that we have when we move into overlap with other NTDs is if onchocerciasis treatment is ongoing, can a country still work on the LF dossier? Jonathan?
That's a good question. I think the country should work on the LF dossier and archive the data and document the achievements in LF. Just as a country without onco, the process will be the same. What we recommend to countries that programs should try to coordinate the impact assessment of both diseases, specifically assessing the onco situation when it's time to conduct the task.
Thanks, Jonathan. We also had a question about STH, and does WHO have any recommendations or guidance for addressing potential STH treatment gaps created by LF-MDA scale down? Jonathan?
Yes, WHO does have guidance, and you can find that in a published manual on integrating STH assessment during the task. So we recommend that a program would assess the prevalence or of STH when MDA is scaling down, and you can do this by integrating with the TAS. And it's a useful tool if the STH program has not already recently conducted surveys. So if there are surveys done after several rounds of MDA, then you would apply the new thresholds, and you can find those thresholds in the LF-STH TAS manual. And based on the prevalence at that time, post-MDA, there's a recommendation of the frequency of preventive chemotherapy for deworming.
Thanks, Jonathan.
Can I add something?
Sure.
About this? So our experience is if we do this integration of STH, that is endemicity with the school child, then it takes double time, because this is not blood. We have to take stool sample. So first day we are taking blood for FTS. So next day they will bring the stool, and the sample size is one school 1 day. So that is also problem for implementation for this type of activity, and actually funding required is double. So with the helping of the CWW, we are doing now community-based stool survey. That is different method. So integration of these two methods in the field experience, to my experience, are not easy actually.
Thanks, Doctor. That's a good point, and it's great to hear the program experience with that. I think we have time for about one or two more questions. Jonathan, and a quick one: is the LF handbook available in other languages?
For the validation handbook.
Yes. Yeah.
Currently, it's only available in English, but we will hope to get the French version available soon.
Great. And I think one last question here: is the dossier development process for other NTDs like trachoma the same as it is for LF?
Yes, actually, this was the purpose of making the generic framework. So the validation is a similar process for NTDs targeted as elimination as a public health problem. Each disease elimination program is responsible for making a specific criteria, which obviously will differ from disease to disease, and there might be some minor differences, but the overall process is the same.
Thanks, Jonathan. With that, I would like to thank Jonathan and Dr. Karim and Dr. Virak for their presentations. We've come to the end of the webinar, and we want to thank everyone for joining today. The slides and an archived recording of the webinar will be sent to you and made available on the Envision website at www.ntdenvision.org. We'll also post a Q&A document online and email to you as well, because there were lots of wonderful questions that we didn't get a chance to answer during the time. I would also like to ask everyone to please use the link provided in the chat box to complete a brief evaluation of today's webinar. We really do want your feedback. So with that, we'll close this session. Thank you again for joining us today.